Hello, this is Annette Rebel. In this presentation, we will discuss the anesthesia consideration when you take care of elderly patients. The presentation will follow following outline. We will discuss the consideration you should keep in mind when you take care of an elderly patient. We will focus on the preoperative assessment, including the frailty assessment, and also include a quick review of geriatric physiology. However, I want to point out that there has been a previous presentation addressing very specifically the changes elderly patients go through in physiology and pathophysiology, and also the pharmacological consideration you should have when taking care of elderly patients. We'll focus on how you modify your intraoperative anesthesia care for geriatric patients, and also go through the postoperative complications you should be prepared for. Geriatric patients are vulnerable. The ability to increase heart rate due to challenges to maintain cardiac output is limited. So therefore, they have less ability to compensate for hypovolemia, hypotension, or hypoxia. Due to the loss of elasticity, lung compliance is decreased, and therefore the lung may be more stiff. The oxygen diffusion capacity is reduced as the alveolar capillary membrane thickens, or losing of alveolar surface, as it would be in emphysema. Overall, the speed of reflexes is reduced, and we see this most in the impaired cough reflex, and therefore less ability to protect the airway. Overall metabolism is reduced, less body fat, and therefore elderly patients are more susceptible to hypothermia. And overall excretion function is limited. Primarily the renal function, the tubular excretion, is affected. So how do we modify our preoperative assessment for geriatric patients? A structured checklist-assisted process for geriatric patients is recommended by the American College of Surgeons National Surgical Quality Improvement Program, also known as NASQIP, and the American Geriatric Society. For geriatric patients, we should include an assessment of the cognitive ability and their capacity, including screen for depression, screen for substance abuse and dependence, and identify risk factors for postoperative delirium. Obviously, you look at cardiac status, pulmonary status, as you would in a normal non-geriatric patient cohort. However, you want to really focus on functionality assessment, the functional status, as it would be the fall history, frailty index, and since those patients are at risk for malnutrition, also the nutritional status. So certain areas we're going to go through more specifically. So as it is recommended by the American College of Surgeons National Surgical Quality Improvement Program and the American Geriatric Society, for as a systematic approach, the cognitive assessment can be done by using the mini-cog examination. It is recommended as a screening process for patients without history of dementia or cognitive impairment. It does not screen for depression. So the mini-cog is a relatively straightforward, not very time-consuming process. It includes a 3-word registration. Then you ask your patient to draw certain configurations on a clock, and then you ask them to recall the 3 words you mentioned before. It's very easy to do, very easy to score, but you do need a person, meaning a healthcare provider, nurse, nursing assistants, to go through that with the patient. You can reach maximal 10 points, and if the patient gets less than 4, this may indicate a need for a more detailed cognitive status assessment. So here is an example of this mini-cog examination. Gives you examples for the 3 words you can use, and you mention that to the patient you are about to examine. You give him some time to go through that. Please listen carefully. I'm going to say those 3 words, and I want you to repeat them back to me and try to remember that. Then you ask him to draw a clock setting here as given as an example. Next, I want you to draw a clock for me. First, you put in all the numbers, and then set the hands on 10 past 11, and you ask the patient to do that. And then, after step 2 is completed, you ask him, so what were those 3 words I asked you to remember? And then you write down which one your patient remembered or not. The scoring, as I said earlier, easy. For every word they recall, they get a point. For a normal clock, they get 2 points. And if those numbers are correct, then you give them the full score, and then you add those scores up, and that gives you the total score. Anything less than 3 has been validated for dementia screening, but if you want to be a little bit more sensitive, NSQIP has recommended to use less than 4. So after assessing the cognitive function, now the question is like overall functional status and how frail is our patient. The process we are recommending here is the Frailty Assessment, giving a Frailty Score. So you see those 5 criteria: shrinkage, weakness, exhaustion, low physical activity, slowness. And the process goes through that you ask your patient either verbally or as a checklist how those functions are accomplished or create limitations. So for every criteria the patient meets, you get a point. And as indicated here in the slide, if you meet 2 or 3 criteria, intermediate, frail; if 4 or 5, for sure frail. So frailty reflects a decrease in functional reserve capacity. Therefore, it can indicate that there's a concern that the patient may not have the ability to respond to the physiological challenges related to surgery. A very important psychological component in the preoperative assessment of geriatric patients is the discussion of treatment goals and expectations. Not saying it's not important for non-geriatric patients, but I think here actually you really have to emphasize that it's important to start thinking, what is the best possible outcome? How do you prepare and set up for dealing with limitations related to the preoperative process and then the post-surgical status? What are realistic expectations? You want the patient and their family to start thinking that they need to plan. So those plans need to be discussed and should be including possible outcomes, the patient's wishes to be discussed not only with the healthcare provider, but also with supportive family. Identify who can support, who will be responsible when the patient is not capable of making their own decisions, hopefully only temporary. Not only the patient, but also the family needs to plan as well. They need to be prepared for the duration of the hospitalization, the needs for postoperative, staying with the patient in then post-hospital. So advanced directive discussion, the healthcare surrogate decisions, all this should be part of your preoperative assessment process, not only by the anesthesia provider, hopefully also initiated by our surgical colleague. Very important to include family and other social support structures, because again, the patient may have limitations what they can and can't do afterwards. And so therefore, others need to be involved in covering those needs. Obviously, to prepare for perioperative and anesthesia care for geriatric patients, we need to be very knowledgeable of changes in physiology and pharmacology applying the situation. However, since there's an excellent presentation from Dr. Schell already available for this topic, I'm only going to quickly review those so we can expand to our anesthesia care, but please do review Dr. Schell's videocast as well. The cardiovascular system is significantly affected by aging. Due to getting older and your arteries getting more stiff, meaning your arterial elasticity is decreased. You can observe that just as normal as pathophysiology is, as a normal finding. Afterload increases with age, your diastolic blood pressure increases with age, and as a response to that, you will observe some degree of left ventricular hypertrophy. There's also decreased activity in the adrenergic sympathognomatic system. The resting heart rate is low, and the maximal heart rate is low as well. So therefore, the rhythm variation is diminished due to less sympathetic tone, increased vagal tone, and less adrenergic sensitivity. To give you an idea how severe that is, the maximal heart rate declines 1 beat per minute per year as you age over 50. As mentioned before, due to the decreased ability to adjust your heart rate to demands, geriatric patients will be less able to compensate for hypovolemia, hypotension. Due to the autonomic rigidity, your reflex status also is diminished, and therefore your baroreflex tone also is decreased. A functional status of less than 4 meds is associated with potential adverse outcomes after surgery. Therefore, we recommend that an EKG for cardiac assessment, because of fibrosis of the conduction system, is performed preoperatively on patients above 65 years old, because there's an increased incidence of dysrhythmias, atrial fibrillation, atrial flutter, to mention a few. If the function status is low or unable to determine, then you also should consider a transthoracic echocardiogram to assess cardiac function. In addition to the changes we already have mentioned, you want to assess for diastolic dysfunction. The fibrosis and normal degradation of muscular tissue will result in a less ability to perform the volumetric relaxation, so therefore decreased filling ability, hence diastolic dysfunction. Also keep in mind that the valvular disease, specifically aortic stenosis, is also more commonly seen in elderly patients. So any kind of systolic murmur really should warrant screening for valvular calcification and more specifically rule out aortic stenosis. So the implication overall is that with diminished cardiac reserve, you will see more exaggerate decreases in blood pressure after general anesthesia induction. The circulation time for IV medications may be prolonged, so therefore the IV induction may be slower. However, inhaled anesthesia induction may be faster. As said before, please keep in mind with all those geriatric physiological changes, your patients are less able to compensate for hypovolemia, hypotension, or hypoxemia. The pathophysiologies or pathologies commonly seen in elder patients, obviously atherosclerosis, coronary artery disease, hypertension, and either systolic or diastolic related congestive heart failure picture. The fibrosis of the conduction system, cardiac arrhythmias, commonly atrial fibrillation or atrial flutter, but you also may see bundle branch blocks and higher degree arrhythmias. And we talked about the higher incidence of aortic stenosis in geriatric patients. So also the respiratory system is affected by age and goes through significant changes as we get older. Age-related elasticity loss allows alveolar overdistension and airway collapse, so therefore a slow decrease in alveolar surface emphysema. That relates to that the residual volume and closing capacity increase. So therefore, even at rest, we have more collapsed alveolar tissue. Even in otherwise normal patients, the closing capacity will exceed the FRC in supine position around probably 45 to 50 years old, and in sitting position probably when you are just above 65 years old. So that's what spirometries have shown. Due to the loss in alveolar surface, your arterial oxygen tension decreases, therefore sets you up as more VQ mismatches, predominantly shunt and also dead space. The chest wall becomes more rigid as a part of, and you all may have seen those emphysematic patients, and just the calcification of your costoclavicular joints due to malnutrition and just loss of muscle tissue, decreased muscle strength. So therefore your cough reflex and cough strength decreases, and your ability to compensate for other physiological stresses by maximum breathing capacity also is diminished. As we already discussed previously, reflexes are all decreased, so therefore blunted response to hypercapnia and hypoxia need to be noted. So what does it mean for us? To prevent the preoperative hypoxemia in geriatric patients, we may need a longer pre-oxygenation time prior to induction. We need to think about a conscientious use of PEEP to prevent airway collapse, and also implement aggressive pulmonary secrete mobilization, since with the weakness of the cough strength. Due to the diminished reflex status, there is an increased aspiration risk present in those patients, so probably a more expedited securing of the airway, and for extubation decisions also you really want to verify that your patient is strong enough to protect their airway. Overall, with increasing age, there's an increased risk for postoperative pulmonary complications due to cough, strength, muscle weakness, and this can be exacerbated by pre-existing pulmonary diseases, sleep apnea, malnutrition, and cognitive dysfunction. So here in this graph, the changes in lung volumes, over time with age. Just to point out that while your total lung capacity really does not change that much as you get older, what increases, as you can see here in that graph, kind of like your closing capacity, this definitely increases with age. Okay. Your residual volume increases with age. So therefore, around 70, here's your tidal volume, here's your closing volume, your closing capacity. Okay, that exceeds, as you get older above 70, exceeds in your tidal volume. Your FRC even exceeds even earlier. Okay. So keep that in mind that they are prone for airway collapse and therefore hypoxemia. So how about other areas? Gastrointestinal, renal, and endocrine system are also affected by age. Overall, the basal and maximum oxygen consumption is decreased as we are getting older. There's a higher rate of insulin resistance and therefore diabetes. The liver function is reduced due to the hepatic blood flow decreases and therefore affects all liver functions, primarily the oxygen-dependent one, obviously. Biotransformation reduces, the albumin production is reduced, and also, one important enzyme for us, the plasma cholinesterase production, also is seen to be reduced. All this gets aggravated as elderly patients also are more prone to malnutrition. So whenever the indicators to point out, if your BMI is less than 18.5 kilograms per square meter, if your albumin is less than 3 grams per deciliter, or if there's weight loss more than 10% within the last 6 months, all those findings are associated with an increased risk for preoperative complication according to the NetScript in AGS database. Renal function are very much affected by aging. In all aspects of renal function are affected. The renal mass and renal blood flow go down, so therefore that correlates to a decreased glomerular filtration rate. Your tubular function also is impaired. Therefore, sodium balance and concentration function go down. The dilution function is affected, and therefore also drug excretion is less predictable. Since the aldosterone renin responsiveness is reduced in the tubular system, we also have an impaired potassium excretion. With all that, it's clear that geriatric patients have a higher rate of fluid and electrolyte abnormalities. And if there are pre-existing, coexisting systemic diseases like diabetes, hypertension, benign prostate hypertrophy, coronary artery disease, and congestive heart failure, all that in addition will affect the renal function and disease progression as well. There are 3 laboratory tests we should consider getting in geriatric patients in the preoperative assessment to gauge if those patients are optimized or at higher risk for preoperative complications. The hemoglobin level. It is recommended for all geriatric surgical patients, especially if the surgery is associated or has a possible significant blood loss, or if the patient has pre-known anemia. Since optimizing of oxygen carrying capacity, addressing existing anemia may actually improve their postoperative outcomes. As discussed in the previous slide, the renal function very much affected by age, so therefore it is recommended for all geriatric surgical patients to get renal function assessment tests, especially if the surgery is relatively intermediate or major invasiveness, or if there are existing risk factors like diabetes, hypertension, cardiovascular disease present, or if the patient takes medications with potential implication on kidney function, as it would be antihypertensive medications, NSAIDs, etc. And last not least, serum albumin as a representation for liver function and for overall nutritional status. Also here there's some information based on serum albumin level. It is recommended to get serum albumin assessment for all geriatric surgical patients, especially if they have known liver disease, serious chronic illnesses or major recent illnesses, if they're undergoing major surgery, or if they're at risk for malnutrition. So now, after setting the stage with the previous information, so now what does all of this mean for my perioperative anesthesia care? Anticipate labile hemodynamics. As studied here in 1997, there are significant hemodynamic changes which will happen with general anesthesia induction, but also with regional anesthesia. And this study here actually looked into hemodynamics after spinal in elderly male patients. The decrease in blood pressure should be anticipated, definitely after anesthesia induction for general anesthesia. If you use propofol, you may need to use smaller doses, but worry about underdosing, because then also you have a high, sympathetic response and tachycardia. So sometimes it makes sense to mix propofol with etomidate to get less hemodynamic implications, but still the depth of anesthesia you need. Since this can happen with general anesthesia and neuroaxial anesthesia, as shown in this diagram, the hemodynamics are affected by spinal anesthesia in the blood flow in elderly patients. In this publication, as shown here, the T4 block decreased the mean arterial blood pressure by 33%, the systemic vascular resistance by 26%, and your cardiac output fell by more than 10%. This is all preload related, since your left ventricular end-diastolic pressure was the driving factor and decreased. And hence here, this is the never-ending question for elderly patients: do they do better with general anesthesia or with regional anesthesia? And while we have some conflicting evidence already, but more larger studies are still in the making, this is something you may have to follow up throughout your career. Since the large randomized clinical trial scales are ongoing to explore the benefit or implication of general anesthesia versus regional anesthesia in the elderly population. The choice in many surgical encounters depends more on the surgical procedure and the comorbidities of the patient. So far, there is no clear evidence that one method is superior to the other. But as I said, more literature is coming. Regional anesthesia is possible, if possible, based on the surgical procedure. That would mean, there's less risk to manipulate the airway. If you go with general, if there any indication, endotracheal tube versus LMA. Endotracheal tube, better airway protection, and also better ability to recruit airway to supply PEEP. But because an endotracheal tube in place, you need more depth of anesthesia, more sedation, muscle relaxation, and also you have less mucociliary clearance. Patients are very prone, elderly patients are very prone for postoperative weakness. So with an LMA, you don't have to expose them to a neuromuscular blockade. Patients above 70 are almost double at risk for residual neuromuscular blockage and adverse respiratory events postoperatively. So it really makes a difference. Well, coming back to regional anesthesia, even if you use regional anesthesia for your surgical procedure, you still may need to give some sedation, since your patient may not be very much cooperative and may be confused at baseline. And so therefore there is a risk of over-sedating, again creating aspiration risk and the implication of giving sedation to elderly patients. For fluid administration, as indicated with those blood pressure fluctuations, no matter what anesthesia technique you use, there is a risk for over resuscitating with fluids, since preload drops, vascular resistant drops, you may respond with that with volume resuscitation. However, when the anesthetic effect is resolved, then you ended up with an over-resuscitated patient and therefore risk for edema. Risk for delirium or postoperative cognitive dysfunction are not only unique for general anesthesia, also this occurs in patients who received regional anesthesia for the surgical event, and so therefore also here it doesn't help you with the decision general versus regional. Complications of the cardiovascular and pulmonary system are associated with significant perioperative mortality. Central nervous system complications are a major source of perioperative morbidity and mortality. The stroke risk, approximately 1% in non-surgical elderly population annually, to give you an idea, but the perioperative stroke incidence compared to that number is increased. Okay, for like about 0.5% of our elderly patients have perioperative strokes. Risk factors are age, atrial fibrillation, here the odds ratio is about 2, the history of a TIA or stroke in the past with an odds ratio of 1.6. Then other risk factors are recent myocardial infarction, COPD or current tobacco use, acute renal dysfunction, or being on hemodialysis, or having significant comorbidities as it would be diabetes or cardiovascular. Strokes most frequently occur within 7 days postoperatively, mostly ischemic and therefore thromboembolic origin. And it has been shown that intraoperative hypotension may increase the stroke risk. There's controversial evidence indicating that the anesthetic depth may affect the perioperative neurological outcome. Delirium is commonly seen postoperatively in elderly patients after regional anesthesia and general anesthesia. And so far, how we understand it is probably multifactorial, but somehow related to the surgical stress. Postoperative delirium is defined as an acute confusional state, postoperatively, occurs approximately in at least 10% of elderly patients, up to 35 to 50% in high-risk procedures. Most commonly, and thankfully short-lived, meaning within 24 hours, but it can persist and it can extend beyond hospital discharge. Delirium can be hypoactive or hyperactive, which is agitation, and especially if it's hypoactive, is very often underdiagnosed. As I said, etiology is multifactorial. Risk factors are age, baseline low cognitive function, as it would be dementia, depression, frailty, general debility, if there is a visual or auditory impairment present, and then increasing the perioperative stress by conditions like stress, pain, sleep deprivation, unfamiliar environment, blood loss. These are all seen as contributing factors. As I said, controversial, but some studies have shown that a BIS-guided strategy with target of around 50 may reduce the risk for postoperative delirium in high-risk patients. Again, this is not uncontested. The other component we have a strong input is pain control. Elderly patients may underreport pain, and the lack of communication, discomfort, and stress may really aggravate the status and therefore the perioperative stress. So as a recommendation, besides avoiding meperidine, okay, and that we should stay away from that just because of the anticholinergic side effects. There is really no superior opiate for pain control. Overall, it is recommended to pursue a multimodal approach. There is no evidence that regional anesthesia or general anesthesia is better, but for postoperative pain control, there may be a role for using regional anesthesia. So postoperative epidural analgesia or nerve blocks may overall reduce the pharmacological needs for systemic analgesia, therefore allow earlier ambulation, early return to normal activities, therefore better neurological recovery and better GI function. As we will be seeing more and more elderly patients in our operating rooms, and it has significant implication for our healthcare system, we really have to ask ourselves the questions, what can we do better for this patient cohort? Those census statements and guidelines from the American Society of Enhanced Recovery and Preoperative Quality, I will actually go through this in a separate presentation following this presentation, and to give us some recommendations where we can focus on and improve. So we're almost at the conclusion of this presentation. Just to tell you, like, no, this is important, and this will be actually more and more a hot topic in your career and your future. We will see more and more elderly patients in the operating room. If you plan on practicing in Florida, currently we are already 20% of your patient population is 65 years and older. This will represent, also a national trend and therefore going higher. So thank you very much for attending this presentation, and feel free to contact me with any questions. Thank you.